Three, two, one. We start. Test sound. Can you hear me?
Yes.
Good. So good. Dear friends, fellow doctors, wherever you are, it's either good morning, good afternoon, or good evening. Thank you for joining us again. I'm actually a founding member of APAGE, and my co-chairperson is Professor Tsuzumi Osamu from Japan. Professor Osamu is also the past president of APAGE. And this is, I read out his CV. Professor Osamu Tsuzumi is professor of Department of ONG, Faculty of Medicine, Tokyo University. From April 2008, he was the director of Sano Hospital. He's also professor, Graduate School of International University of Welfare and Health. He's auditor and past president of Japan Society Gynecologic and Obstetric Endoscopy and Minimally Invasive Therapy. He's past president of Japan Society of Fertilization and Implantation. He's past president and past Congress president of Asia Pacific Association of Gynae Endoscopy, which is APAGE. He's also the president of Obstetrical and Gynecology PRP Treatment Study Group. My panelist is Dr. Bae Swan Tiong, good friend of mine. He's also the past president of ONG Society. He is invited as my resource expert. In other words, he'll handle all the difficult questions. He's a familiar face to all laparoscopic fellow doctors who has been through KK Hospital and trained by him. And every time I'm overseas, especially in China, the lady doctors will come up to me, but ask about him. Okay. Again, today we would like to share with you on HIFU, which stands for High Intensity Focused Ultrasound. This is a procedure, I think, will change the practice of gynecology and will add a new dimension to treatment of uterine fibroids and adenomyosis. And the machine we are talking about is this machine called JC model, or I call it the virtual knife. Why virtual? Because the sound comes out from this basin, and you can't see it, but it delivers ablation power like a knife. This is brought to you by two organizing societies, APAGE and ISMIVS. APAGE stands for Asia Pacific Association and Minimally Invasive Therapy, founded in 2003. And here are my friends. From the right, Professor Li Qilong, the chairman of APAGE. I think this is Dr. Bruce. This is Professor Harry Rich, the man who introduced laparoscopic hysterectomy to the world. And to his right, on my left, is Professor Prashant from India, and he is the president-elect of APAGE this year. Behind are all my friends from Japan and Korea. This is a newer picture of Professor Li Qilong. This is a very familiar face, especially people from Sydney, Australia, and Hong Kong, and the Delta region. Professor Felix Wong, myself, and this is a good friend from Malacca, Malaysia, past president of APAGE, Dr. Salva, and to his right is Dr. Hugo from Germany, and to his right is Dr. Zhang from Taipei. ISMIVS, and this is a big board of ISMIVS members. In the center is Professor Cranston, I think this is Gail, and the friends from Thailand, and this is doctor from South Africa, Raymond, and then my friends from Egypt. Behind is Rosie, Dr. Choi, who gave the talk last week, and my friends from Spain, and all those from Taiwan, Japan, Korea, and let me see, and many Asian countries is Professor He Jia. This is my teacher, Zhang Lian. To his right is Professor Wang Zibiao, and then the rest are from Taiwan and China. It's a big board. Again, the highlight of this 4 webinars is we are talking about HIFU, and to just briefly explain, there are 2 types of HIFU in the world right now. One is MRI guided, which gives mainly a thermal energy, less ablative, versus ultrasound guided HIFU, which is more ablative. So there lies the difference. And afterwards, Professor Zhang Lian will explain the difference. But to me, the main difference is it is more efficient compared ultrasound guided HIFU to MRI guided HIFU. And what is interesting to me is because unlike the MRI guided HIFU, the ultrasound guided HIFU can be used by a gynecologist, or in other words, almost any doctor, trained doctor, a radiologist. It is ablative in nature, and the duration of ultrasound guided HIFU is independent of the MRI machine. So you can actually put the MRI machine to better use and not occupy it for 4 or 5 hours. We have 4 webinars. We have completed 1 webinar on the 11th of June, Thursday, and today we are the 23rd of June, Tuesday. And all in all, we have about 20 experts plus 1 mystery guest. Okay, this webinar, we have, the past webinar that was done some time ago, we have 2 speakers. One is Professor Prashant from Mumbai, and the other speaker is Dr. Choi from Korea. Just to recap, these are the highlights by Professor Prashant, the president-elect of APAGE. He said, you need good preceptorship, practice, hard work are the ingredients needed to become a safe and skilled laparoscopic surgeon. He does not believe in needing a bag for laparoscopic myomectomy because myomectomy in itself would have upstaged the leiomyosarcoma. The risk of leiomyosarcoma is very low and not about 1 in 350 mentioned by FDA. A statement from the Society of Gynecologic Oncology USA in December 2013 states, leiomyosarcomas offer an extremely poor prognosis even when the specimens are removed intact. And I quote, this is Professor Prashant's famous analogy, morcellating a myoma in a bag after removal is like using a condom after sex. This summarizes everything. He also discourages the use of ulipistol acetate for the treatment of myomas after reports of liver impairments. That's a summary from Professor Prashant. And Dr. Choi Dong-ship from Korea, his summary, his take-home message is, HIFU is recognized as a safe and efficient technology in treating uterine fibroids with good results in symptom improvement, shrinkage, and quality of life. His choice of ultrasound-guided HIFU over MRI-guided HIFU was for its real-time monitoring ability, ablation power effectiveness, and patient safety. Now, today we are in part 2, and in part 2, let me invite the first speaker of part 2, a good friend of mine, Professor Bernard Chen. And his topic is on uterine fibroids, when to operate and when not to operate. This topic I chose from a series of lectures given at APAGE, and this is one of those lectures which I thought was concise, precise, and a very good take-home message. A little about Professor Bernard Cheng. Is the head and senior consultant of MIS unit of KK Hospital, Singapore. In 1996, he undergone fellowship with Professor Chris Sutton in UK and with Dr. C.Y. Liu, founding member of APAGE in Tennessee, USA. Associate Professor Chen's professional appointments include the following. He's Chairman, Division of ONG in KK Hospital from 2014 to 2019, which is just stepped down. He was President College of ONG Singapore from 2011 to 2013. He's a member of the advisory board and past president of APAGE. He's a board member in Asia Pacific Gynecological Endoscopy Training. He's a board of trustee Asia Pacific representative AAGL from 2014 to 2015. And in 2010, he organized the 11th APAGE Annual Congress in Singapore successfully, followed by equally well-received regional APAGE meetings in Singapore annually. Indeed, he has contributed tremendously to the advancement of MIS in Asia. Now, without further ado, I invite Professor Bernard Cheng, past president of APAGE, and his topic is uterine fibroids, when to operate and when not to operate. Over to you, Bernard.
Right. Thank you, KY, for your very kind introductions. Can you all hear me clearly from my microphone?
Okay.
Good. Thank you. All right. So I will go on to my PowerPoint. Just give me a second. Share screen. Can you see me? Can you see the PowerPoint?
Okay.
Good. All right. Thank you very much. Sorry for the slight delay. Okay. So today my topic is about fibroids and fertility. The question here we are asking ourselves is that when should we operate for women who have fibroids and are keen to conceive? So my talk today will touch on the classification of fibroids, which I think is very important because that should be the basis how we're going to compare outcomes in various clinical trials. And I also touch on how does the various possible mechanisms that fibroids may affect the fertility potentials of a woman, and of course to examine the current data that is available to us, especially the various clinical pregnancy outcomes in women who are suffering from fibroids. Then, of course, we have to discuss briefly the various management of fibroids when women are suffering or having fibroids and they desire to have more pregnancies, the various surgical options, and of course the alternatives as well. So I'm going to run through this classification. This is a FIGO classifications of fibroids locations. And of course, we are familiar that for type 0, type 1, they are essentially submucous fibroid. Type 2 are submucous fibroid, but there's a significant proportion in the intramural locations. Then type 3, type 4, and type 5 basically are located in the myometrium, all right? And the type 5 has a subserous extension. So the way that fibroids causes fertility issues are not fully understood. But in some instances, it is pretty obvious because huge fibroids, especially those located very close to the fallopian tube, can cause obstructions to the fallopian tube and thereby causing a fertility issue. And some authors believe that the presence of fibroids may alter the uterine contractions and the uterine peristalsis and therefore affecting implantation. And some authors feel that the changes in the implantation factors may affect the embryo implantation as well. So let's take a look at some of the data that's currently available. Elizabeth Prentice publishes a paper in Fertility and Sterility quite a few years ago, examining the issues of fibroids on fertility. I think it offers a very good insight into some of the problems that we face as a clinician every day. It is a systematic review with meta-analysis looking at 23 studies in total. But unfortunately, there's only one randomized control trial. If you take a look at the data, if you just look at the submucous fibroid portion versus those women with no fibroids, it is quite clear there is significant decrease in the patient's implantation, clinical pregnancy rate, as well as live birth rates. And this is also associated with the increase in miscarriage risk. And the magnitude of reduction, we are looking at 60 to 80% reduction. And this is, I believe, most of us, we encounter this during our day-to-day clinical practice. And women with significant submucous fibroid often come to us, not just with recurrent miscarriages, unable to get pregnant, and sometimes associated with abnormal lie in subsequent pregnancy and so on. But if you look at the data on the intramural fibroid versus women with no fibroids, it appears to have a reduced implantation rate for those women with intramural fibroid associated with a lower live birth rate as well. And similarly, this is associated with the increase in miscarriage rate. But if you tease out those studies whereby hysteroscopy has been performed, then you find that women with intramural fibroid, they do suffer from a reduced implantation, but there's no apparent effect on the clinical pregnancy rate or a live birth rate. So it is important to have proper evaluations of the uterine cavity when you are conducting a trial comparing the various types of fibroids on fertility. So the question is that if a woman do have fibroids and suffer from infertility, does surgery help them? So it is quite clear that if you have submucous fibroid or intracavitary fibroid distorting the uterine cavities and shape, removal is generally recommended because it is believed that these fibroids causes pregnancy issue and removal will enhance your fertility. If you look at the same study, comparing women with submucous fibroid surgery versus no surgery, you find that the pregnancy rate is almost double after the removal of submucous fibroid. What about women with subserious fibroid? I think most of us will believe that there's no evidence that removing subserosa fibroids will improve fertility, pregnancy rate, or other obstetric outcomes. Of course, we do know that large fibroids in pregnancy can potentially undergo degeneration, etc., and causing pain. But itself is generally not believed to be a factor for infertility. But however, you may have to consider surgery if a hysterosalpingogram demonstrated occlusions of the tube is occurring because of the subserious fibroid. So the next questions are the intramural fibroid. I think this is the most controversial, especially the type 3 fibroids. Now, we look at this paper, which again is a systematic review and meta-analysis published by Sankara from the guys at St. Thomas Hospital, NHS. This analysis included 90 observational studies comprising 6,000 over IVF cycles. And they found that patients with fibroids non-cavity distorting intramural fibroid is associated with the reductions of live birth rate by about 20%. And they are looking at a group of patients who are undergoing IVF treatments. And if they do have fibroids, they find that there's a reductions in the success of your IVF cycles. Then the next paper, published by Lei Yan from the Shanghai University, examined the effect of type 3 fibroids on IVF again. This is a retrospective study. And they found that if there is an intramural fibroid of larger than 2 centimeters, the patient will have a lower chance of having a successful implantation, a lower chance of having a clinical pregnancy, and a lower live birth rate. But there's no associated increase in the miscarriage rate. And this paper again examined the effect of a fibroid size on the mechanism of a fibroid causing fertility chances. And it reported that the live birth rate in women who have 2 fibroids or more, or if the fibroid size is more than 3 centimeters, the patient will have a reduced chance of a successful pregnancy. But the problem is that if we do look at the various data that's available to us, they are derived from studies, mostly heterogeneous. The numbers from some of these studies are very small and underpowered, and most are descriptive studies. And very often, the intra-cavity assessments will not perform. Most of the fibroid locations were reported based on the ultrasound examination. And we all know that ultrasound may not accurately report and localize some of the fibroids, especially with the submucous extension. Proper diagnosis with hysteroscopy, MRI, and the saline sonographies are often important, and because this is the way that you actually would tease out the submucous fibroid from the pure intramural fibroid, and you can more meaningfully compare the obstetric outcome and the pregnancy outcome. So, even if you do believe some of the data that's currently present, that intramural fibroids can affect your pregnancy, the next question is that by performing surgery, or in this case, we are looking at performing myomectomy, reverse that trend. Can surgery improve their pregnancy after they have gone through it? This is a single center studies in Cleveland against the retrospective studies over a long period of time, 10 years. And they found that the patients, whether they have fibroids in situ, nothing done, or patients who have no fibroids, or patients who have fibroids have undergone myomectomy, the differences in their live birth performance is not significantly different. Those who had myomectomy appear to have a faster time to pregnancy, but at the end of the day, there were no significant difference in their cumulative live birth rate. So going back to Elizabeth and Pritch's paper, again, she has drawn the same conclusions that in patients with intramural fibroid, whether surgery has been performed or not, there were no significant difference in the ongoing pregnancy or the live birth rate. So that basically from these 2 papers, more or less, we can tell our patients, even with the performed surgery, we cannot guarantee that their fertility will be enhanced. But we know one thing for sure: performing surgery on the womb, removing fibroids, definitely carry with itself significant surgical morbidity. We're all familiar with the post-operative adhesion formation. It can give rise to pain, it can cause obstruction to the fallopian tube, and more fearful, of course, is the risk of uterine rupture. Because when the cavity is breached, there's a risk that the uterine scar will give way. These are some examples, some of the papers were showing the chances of patient developing post-operative adhesions after myomectomy, and we are easily looking at 50 to 70% chance of adhesion formation And of course, associated with that, the subsequent possible complications such as colic or even intestinal obstruction. Then if you do examine the risk of uterine rupture, and we can conclude that the risk of a woman who had myomectomy before has a chance of her uterus rupturing of 1.5% even before the onset of labor, and intrapartum, the risk again is 0.5%. And if you add these two together, that means that the patient will have to face a risk of uterine rupture either antenatally or intrapartumly up to 2 to 3% possibility. And that's the reason why it is not surprised that ASRM has made very few conclusive recommendations on the management of fibroids in patients relating to fertility. If you look at it, under grade B recommendation, essentially it says that submucous fibroid should be removed by hysteroscopic myomectomy, and it shows that that will improve clinical pregnancy rate. But if you look at others, in terms of the possibility of intramural fibroid affecting pregnancy, surgery removing intramural fibroid to enhance pregnancy, did not receive any significant data support or evidence support. So then, if you think that submucous fibroid 0, 1, or type 2 surgery is useful, then what are the challenges we face? The surgical approach to this group of fibroid logically should be performed via hysteroscope, because that will protect the myometrium without causing a hole in the myometrium and therefore the risk of uterine rupture. But of course, if you have fibroids which are larger, and especially the type 2 to type 5 extending to the subserous surface, and this fibroid perhaps may have to be removed laparoscopically or via open myomectomy. If you do compare these two, especially if you are just looking at type 0 to type 2 fibroid, I often ask myself, which is the better approach, especially if they are larger? The smaller one is quite clear if we remove it from below hysteroscopically. But the larger one, what about those who are 4 centimeter, 5 centimeter and above? And especially they are type 2, perhaps only part of it is in the submucous cavity, in the submucous location, and the bulk of it is in the myometrium. Which is the better approach? If you look at it, hysteroscopic myomectomy, advantage, as I mentioned, uterine cavity not reached, less damage to the integrity and the strength of the uterine musculature, and you don't have to worry so much about uterine rupture. But if you have a large fibroid, when you resect a large submucous fibroid, 4 centimeter, 5 centimeter, you can imagine large amount of endometrium will be removed as well. And then what are you faced with? So yes, on one hand, we know that by removing the submucous fibroid will improve the fertility. But now you are to face another challenge then. What about the intrauterine adhesion formation, Asherman syndrome? So on one hand, you think that removing the fibroid may improve fertility because improve implantation, etc. But at the same time, if you end up with the intrauterine adhesion formation, especially if you're talking about larger fibroid, you are going to neutralize all the benefit of surgery. Laparoscopic myomectomy, better, right? In that case, let's say a 5 centimeter type 5 fibroid, you were able to protect the endometrial lining. You're able to preserve that. Therefore, there will be less problem of Asherman syndromes, intrauterine adhesion formation. But then you are trading it for what? You're trading for a weakened uterine musculature and an increased risk of uterine rupture when she does get pregnant. So in conclusion, among the various locations, intramural fibroid, it is the most challenging. Submucous fibroid is clearer, removal does improve fertility outcome. Subserious fibroid, no, it's quite clear as well. But intramural fibroid, the evidence that we have thus far is possibly associated with lower fertility outcome. The numbers, the size, the exact location may play a role. Unfortunately, the existing studies that this evidence would derive perhaps have included some submucous fibroid as well, as their location are often just ascertained based on transvaginal ultrasound. And very often, HSG, hysteroscopy would not perform. And the next questions, on the next challenge we face is that there is no level 1 evidence that if you to perform surgery will improve fertility. But for sure, we know that surgery is associated with adverse fertility outcome, such as adhesions formation, uterine rupture, and so on. So in that case, shall we operate? Consider surgery if the location is blocking the ostia, obstructing your oocyte pickup, or if you have patients who are symptomatic, who have bleeding, hemorrhage, etc., I think the options for non-surgery will be lesser. Essentially, more studies are required, and we need more precise fibroid locations and definition, and they may require MRI or hysteroscopy for better conducted studies. And hopefully in the future, we have more evidence that we can work on to make more more suitable clinical recommendations to our patients. With that, thank you.
Can you hear me?
Yeah.
Okay, good. Thank you, Bernard. That was, again, I would say is concise, clear, and really classy summary of what to do when you're faced with a fibroid, to operate or not to operate. However, we'll leave the questions to the end. Right now, I would like to invite Professor Osamu Zuzumi to introduce our next speaker. Professor Zuzumi, you have to on your microphone. Yes.
Okay. So, thank you for inviting me for this interesting meeting. And it's my great pleasure to introduce next speaker, Dr. Ben Xuan from Singapore. And can you tell me the file?
Yeah.
Oh,
Can hear you.
good evening. And may I introduce Dr. Bear? This one? Or can you QED? Do you have this?
Yes,
file?
I have. Yes, I have. You want it on a PowerPoint, is it?
So, will you open the? Oh, thank you. Yeah.
Okay.
Today, an update on complications of laparoscopic myomectomy is the title of the talk. And maybe next slide, yeah. He is consultant obstetrician and gynecologist, Tom Ben Clinic for Women, Thompson Medical Center, and also senior consultant, minimally invasive surgical unit division, KK Hospital, very famous hospital. And visiting consultant OBGY Singapore General Hospital, and chairman, Singapore OG Group. And his training is in minimal invasive surgery in 1996. Professor Kenneth Hatch, Department of OBGY, University of Arizona, USA, and also C.Y. Liu, Tennessee, and James Daniel, Nashville, USA, and President of OBGY Society of Singapore, 2007 through 2009. So I'm looking forward hearing an update of complications of laparoscopic myomectomy from Dr. Ben Sean Kyung.
Thank you, Professor Suzumi. Shall upload my screen.
I can show you. So please start, Professor.
Okay. Can you see my slides? Okay, good. Thank you very much. Thank you, Professor Suzumi. Thank you, Professor Lee, for the invitation. Wow, this is the time of the day in Singapore, the very famous view that some of you might have been there before, our iconic Merlion facing the Marina Bay Sands Integrated Resort. I hope to welcome you physically in Singapore soon. In case you want to know where is Professor Lee's office, there it is on top of the MBS.
Oh, please.
No, I'm just joking. All right. Okay, I'd like to thank also the organizing committee of APAGE and ISMIVS for the invitation to this webinar. And my topic today is on update on complications of laparoscopic myomectomy. This is where I practice, Thomson Medical Center, and I'm also a visiting faculty to the minimally invasive surgery unit in KK Hospital together with Professor Bernard Chen. Just a very brief introduction. I'm sure all of us witness increasing demand of myomectomy from our patients. The reasons are basically myoma is a disease that carries a huge disease load in the population. And despite the availability of many non-surgical options, surgery still remains a mainstay of treatment. The general delay in childbearing age increases the risk of fibroids in these women and the need for intervention as well. Myomectomy is increasing favored by patients, even for those without further fertility demand, as they long for organ preservation nowadays. And laparoscopic myomectomy, with its well-known benefits of being minimally invasive surgery, is very sought after by patients. Just to illustrate my point, comparing the 2 years of statistics from USA, 2011 to 2015, we can see the colored portion of the chart that myomectomy has increased together with the endoscopic approach, being hysteroscopic and laparoscopic myomectomy. It's estimated about 34 to 40,000 of myomectomies per year in USA. A similar trend can be observed in UK. My lecture today will divide into 3 portions. We shall just very briefly revisit the list of complications and spend a bit of time to identify the limitations and specific problems associated with this procedure, and at the same time to discuss the recommendations and solutions. I'm sure the list of adverse events or complications in this table is very familiar to all of us. It reflects the general complications that we can tell the patient for every laparoscopic procedures. However, we're more interested in those that is perhaps more specifically associated with laparoscopic myomectomy. And in the interest of time, I'm basically going to concentrate on 3 areas, namely hemorrhage, uterine rupture, and undiagnosed sarcoma. This is an estimated range of incidents. And just to further emphasize on what Professor Chen has mentioned earlier, adhesive disease following myomectomy is a very common problem. About 1/3 to 2/3 of patients will develop that. And this is especially important in patients with fertility requirement. We shall quickly move on to the next part of the talk, basically to identify the limitations and the problems. We all know that uterus is a very vascular organ. Fibroids can be huge, can be multiple, and yet laparoscopic suturing, no matter what, is still slower than open approach. It's important to repair the defects of the myometrium well after enucleation of the myoma to achieve three objectives, in fact. Number one, to stop the bleeding effectively and quickly. Number two, so that the myometrium can heal strongly and preferably without much adhesions. Failing to do so will, number one, lead to uncontrolled hemorrhage. Serious hemorrhage during myomectomy commonly lead to laparoconversion. And of course, it depends on the experience of the surgeons and the center. And various reports has give a range of conversion to open myomectomy up to 17%. This is the higher end will probably be associated with centers that newly embark on laparoscopic procedures. Sometimes even lead to unplanned hysterectomy, ranging from 0.3 to 2.7%. And usually when this happens, especially in patients when there's still a demand for fertility, it will spell huge trouble. Some papers analyze the risk factors for intraoperative hemorrhage. And in this systemic review, it concludes that the size of fibroid does matter, especially when it's more than 6.5 centimeter onwards. The numbers when it's more than 3, and the location of fibroids being intramural compared to subserious. What are the tips that is available for us to utilize to help to reduce this problem? I think all of us realize that prophylactic hemostatic control is something very important in laparoscopic surgery. And this concept is even more so for myomectomy. Secondly, we do need to have precise and effective electrosurgical hemostasis for active bleeding vessels, while the diffuse widespread oozing in the myometrium should be managed by suturing. And good and quick layered repairs are important to arrest active bleeding and avoid hematoma formation, except for perhaps pedunculated fibroids. Let's just run through what are some of the strategies that can help to overcome this problem. I think many of us have the experience of using preoperative GnRH agonists. It is well known to be effective in decreasing vascularity and the size of the fibroid. It is not my favorite, however, because I always find that it makes the fibroid softer, make it more difficult for traction and morcellation. Smaller fibroids tend to kind of disappear, make it difficult, especially those that is intramural, to detect during the surgery. And that may, I feel, lead to higher chance of recurrence. And of course, we need to give it a couple of months before the operation to expect a shrinkage of about 30 to 50%. It is, however, useful for patient who is anemia because it helps to reduce the bleeding and allow time for the hemoglobin to build up. Ulipristal acetate or ISMIVS, 5 mg daily, has also been shown to be able to produce similar effect. However, the drugs has been temporarily suspended due to its associated liver toxicity. This is an old paper published in 2009, a Cochrane review of all the strategies that is available to help to reduce hemorrhage during myomectomy. So these are the methods that they review. And there's a list of fantastic 5, I call it. Namely, these 5 agents seems to be the most effective. Pericervical tourniquet is the most effective of all, but however, its usage in laparoscopic surgery is probably quite limited. The next best thing will be the vasopressin. And in countries where this drug is available, I believe it's very commonly used because it does help a lot in reducing intraoperative bleeding and allow us to tackle fibroids that are huge and multiple. Some intraoperative techniques is also useful. Uterine artery occlusion as its origin is particularly useful when you're dealing with very big fibroids, as this can be very vascular. As you can see, this is a huge, this is a huge blood vessels, uterine vessels. However, this is a complicated procedure and should be only performed by experienced hands because by itself can lead to severe complications as well. Professor Prashant did mention about in his earlier lecture about the choice of uterine incisions, whether vertical or transverse. I concur with him that a horizontal incision is perhaps better. And if you look at the architecture of the uterine vasculature, it makes sense that a transverse parallel incisions to the vessels would reduce the number of blood vessels that you will sever when you cut through it. Remember, the second objective of the repair is to allow the tissue to heal strongly. Hence, we should avoid overzealous electrosurgery as this will lead to tissue necrosis and poor tissue healing. Effective suturing is also important as insufficient layers of suturing or poor technique may actually lead to poor tissue apposition, lead to defective healing or hematoma formation. And this will lead to the next thorny problem that Professor Chen alluded to earlier on too. The issue of uterine rupture after myomectomy. It is rare, reported roughly to be from 0.6 to 1%, but disastrous. The problem is rather difficult to assess accurately and is likely underreported. Hence, we need to turn to some systemic review on this problem. In this article, published in 2014, the authors analyzed about 27 published articles of about 2,000 over myomectomy, a mixture of majority laparoscopic, some open, and some TCRM. And in this study, they reported 29 uterine ruptures that make an incidence of 0.7%. All but one occurred prior to the onset of labor. 80% happened between 28 to 36 weeks. It's a big range, all right, but 80% of them happen premature. There's a higher trend after laparoscopic myomectomy compared to open myomectomy. However, statistically, it is not significant. Yet another paper looking at the trial of labor after myomectomy and uterine rupture, published in 2016. Out of the 1,008 deliveries or so, there were 11 cases of uterine rupture, making an incidence of about 0.6%, 70% of which is after laparoscopic myomectomy, about 30% after open myomectomy. And again, majority are before 36 weeks. So it leads to a huge problem of prematurity and neonatal mortality. This is an unpublished series from KK Hospital. Thank you to Professor Chen for allowing me to share this data. This is during a study period of 12 years from 2003 to 2014. There were 50 cases of uterine rupture recorded, and making an incidence of 1 in 2,000 deliveries. Out of the 50 cases, 10% were associated with previous laparoscopic myomectomy. And they were all done in other hospitals, not in KK hospitals. And all these 10% again occurred antenatally and before the onset of labor. So what can we learn from all these studies? Number one, uterine rupture after myomectomy tend to happen before the onset of labor. It can happen as early as middle second trimester to early third trimester. Hence, a planned cesarean section should be earlier rather than later, perhaps once the baby reaches 36, 37 weeks. And interestingly, those that go through the antenatal period without much problem and enter labor spontaneously at term, the risk of rupture is similar to VBAC. Probably this represents the group of patients whose myometrium after myomectomy heal rather well. So to reduce the risk of rupture, again, I need to emphasize, avoid excessive electrosurgery, good and proper stitching, multiple layers is preferred. We know that laparoscopic suturing is more difficult. However, with appropriate practice, training, and experience, it can be comparable to laparotomy. If there's real difficulties to achieve this, surgeons are always able to enlist other forms of help if the resources permit. For example, you can resort to robotics, which is good to enable a surgeon who can't suture well to provide proper stitching. Or the use of bulb sutures can also help to anchor and enable a better closures of the myometrium. However, I feel that for patients who desire future pregnancy, if there's any doubt on the quality of the repair, laparotomy is preferred. I think the tragic consequence of uterine rupture in the future pregnancy far outweighs the benefits of minimally invasive surgery. As I was doing literature search in preparation for this topic, however, I come across some interesting anecdotal evidence of repairing the ruptured womb when it happened as early as 21 weeks or 15 weeks. And as long as the baby was still okay at that time, despite the massive hemoperitoneum or the rupture, repair of the womb helped to actually delay the delivery of the baby up to about 10 to 12 weeks later. Hence, it brings a pre-viable fetus to a viable fetus. So this is something that you may want to consider if unfortunately there's such a case landed on your desk. Next, we need to look at the morcellation issues. Morcellations is an inherent part of laparoscopic myomectomy because we are essentially trying to remove a large firm tissue through a small hole. It's like this man squeezing through the rocks. So it's needed for any sizable fibroids, whether using power or non-power, abdominally or vaginally. Of course, it's not without its risk. There may be inadvertent visceral injuries, especially intestines, and leftover fibroid pieces can lead to parasitic fibroids. or disseminated peritoneal leiomyomatosis. It's a unique sequelae due to morcellation, and the common locations tend to be at pouch of Douglas, mesentery, omentum, or in fact anywhere in the abdomen attaching itself to the parietal peritoneum. Like this patient, she has a parasitic fibroid growing just below the subdiaphragmatic area. This is the liver and that's the gallbladder. This is another patient, 45-year-old with previous myomectomy for multiple fibroids, presented 7 years later with left iliac fossa painful mass. So an 8 centimeter parasitic fibroid was seen attaching to the left lateral wall at pelvic rim. So this is the fibroid. It was originally covered by the omentum and intestines. So after gentle separations, slowly after dissection, the fibroids emerge. This is the full view of the fibroid. It looks rather bizarre, in fact, and very vascular. And for a moment, I was quite worried, could there be any sarcomatous changes? And this is just to show the uterus, the fallopian tubes, and the ovaries somewhere there. So the fibroid originally occupied this entire area. So it is a good habit, number one, to count how many fibroids have we removed. Visually follow closely the picking up and morcellation of every fibroid. Meticulous removal of all the visible pieces. And morcellate as long a strip as possible, avoid pulling too hard, and have a good assistant to help you in this. And contain morcellation within the back may help to reduce this problem as well. The next topic that we like to discuss is actually the difficulty to differentiate sarcoma from leiomyoma. This is not a new problem that we face. Ever since myomectomy is performed, we know we may face this problem because it is simply very difficult to differentiate sarcoma from leiomyoma preoperatively. There's nothing reliable. However, the problem becomes sharpened and come into focus with laparoscopy and power morcellation. Of course, this whole issue was brought to the limelight by FDA's safety alert since 2014. I shall not go into that because I'm sure we are all very familiar. In the first place, the data that FDA quoted has been thought to be rather high, very contentious, and many organizations have come up with their own studies and own statistics. It's estimated, however, is still around 0.2% or so. Not only preoperatively, but intraoperatively, it is very difficult to differentiate. Which one do you think is fibroid? Which one do you think is sarcoma? We need to base on some parameters to help us to further that, to try to exclude sarcoma, although it's not very successful. We know that most of the time, sarcoma rarely happen before the age of 40. Of course, this is not foolproof. The clinical presentation is not really helpful. Patients with some risk factors, these are the common risk factors that is cited, but they are very rare stuff. Ultrasound features, MRI features are not exactly very predictive. There's been some tests on LDH isoenzyme 3 and are supposed to help in the detection. And endometrial biopsy, right, has been thought to be able to help to diagnose sarcoma in 38 to 66%, especially in women with abnormal uterine bleeding. And the European Society of Gynecological Oncology advocates that as part of the workup for sarcoma, endometrial biopsy should be included. How useful is MRI? Well, it does offer some clue. There are some studies that mention that leiomyosarcoma does not form calcification. Presence of intralesional hemorrhage make it more suspicious. Similarly, for irregular margin. And in some situation, gadolinium contrast may help to improve further the detection rate. A few practical questions that I like to ask is, what is considered adequate evaluation of fibroid? Does every case require MRI, endometrial histology, LDH, etc.? How often are sarcomas missed actually? Especially, there are so many fibroids and many of them receive non-intervention or non-surgical intervention. There are anecdotal reports available, but there's no proper reporting registry. Is myomectomy or only myelomosilation that worsens the prognosis if cancer is encountered? And is power mosylation worse than other forms of mosylation? Remember this was the picture I showed you earlier on? It belongs to a case of unexpected uterine leiomyosarcoma after treatment of 6 months with uric crystal acetate. The patient finally went for surgery because the symptoms did not improve, and contained power mosylation was done. So power mosulator, is it a necessary evil? We know that it is a great innovation and help a lot in laparoscopic myomectomy to facilitate and cut short the operating time. However, it is associated with disseminating malignant cells and worsen of prognosis. You may argue that there's no prospective, well-designed data to confirm this, but however, multiple retrospective cohort studies, etc., do support this. It disseminates benign diseases too, as we mentioned earlier, risk of inadvertent injuries to other organs. However, I think this is operator dependent, and disruption of pathology specimen. Because without this, the alternative would be either laparotomy, mini laparotomy, vaginal or colposcopy extraction, or using scalpel or Caesar mosylation. This is an interesting study published by the Agency for Health Care Research and Quality in 2017, where they look at 24 studies and analyzed 384 leiomyosarcoma. And with statistical modeling, they try to correlate mosylation method to the 5-year survival rate. And they find that when there's no mosylation done at all, 5-year survival rate is 60%. When you use scalpel to mosylate, not much difference. But when power mosylation is used, it dropped by half to 30%. Of course, all these data provide a feeding frenzy for the lawyers, especially in the United States. This year in February, FDA kind of updates its advisory. It recommends performing contained mosylation in women when laparoscopic power mosylation is used. And this position is also adopted by ACOG, AAGL, and Society of Gynecologists Oncologists. So that leaves us with 4 groups of gynecologists. One would perhaps perform laparotomy for all patients that require myomectomy. Another group of patients that would just do as what they have been doing without any change in the practice. That means they'll do myomec, they'll mosylate everything as usual. Or those that do selective mosylation only for perhaps the so-called low-risk group for leiomyosarcoma, those that is below 40-year-old or 50-year-old, depending on the threshold. Or another group that will perform mosylation in back for all cases. There are a couple of these containment modulation bags available in the market, depending on which country you are. So far, Pneumolinear from Olympus is the only one that is FDA approved. However, this system, although is smart, but it's probably more designed for single incision laparoscopy because you require a 2.5 centimeter incision to insert the system and to utilize it. With a 2.5 centimeter incision, I think we could do this. Put a fibroid in with the back and use a scalpel modulation quite effectively and quickly. In Singapore, this is one of my case, patient multiple fibroid. The only bag that is available to us is more safe. I think it's manufactured from India. All right, so this is when the back fibroid is put in a bag and this is a modulation. This is the marking of the bag. However, the bag is not foolproof. There are unresolved questions about it. It does add more operative time. You may require more pots, bigger pots, more assistance may be needed, and it's not that cheap either. It's not proven to completely prevent malignant cells leakage physically, and there's obviously user's problem as well, inadvertent perforation of the back or spillage. So it is meant for cases, not meant for cases suspicious of malignancy, but only for cases presumed benign. I'd like to end my talk that laparoscopic myomectomy benefits women, but competent surgical expertise is important to ensure good outcome, especially if future fertility is desired. Judicious use of power modulator is justifiable. And I do urge that we should consider contained modulation, because this may further reduce the risk to patients as well as some medical legal problem to the surgeons. With that, I thank all of you.
Okay, thank you. Thank you, Dr.
Thank you
Gay.
very much.
Thank you, my friend Suan Tiong. Okay, that was really, really thought-provoking. So thought-provoking that many of us won't be able to sleep tonight. But anyway, you have brought home a very difficult topic very well. And I would say we just have to keep our fingers crossed. Maybe the next speaker, which I'm going to introduce, can bring some answers to all the problems related to fibroids and myomectomy. Can I have my slides, please? Next one. Okay. Here I have, before I introduce the next speaker, I have to let you have a look at this map of Asia, which features China in the center. And we are talking about a place called Hyphen, which appears like as a dot on this map. But if I choose another map, okay. Chongqing is the arrow here, is actually a province which they call municipality, meaning it has its own governance and corporate structure. Now, if I take away all these colors and look at it this way, it is actually not a small place. It's really a very huge area, as big as Taiwan and even South Korea, bigger than Hong Kong and of course Hainan Dao. Now, before I stepped foot onto Chongqing, I was very scared because my first time there was a few years ago. I thought it's still a very laid-back place, still backward, which toiletries, toilet facilities are limited. Maybe I can't find the food I liked, and I heard that they don't have motorized boats and they have to pull the boats by labor, manpower. up the rivers, and sometimes upstreams you get very strong young men, almost naked, because they're always wet pulling the boat. So that was my fear before I touched down into Chongqing. But when I arrived, it was really, really a culture shock. Something which I always said is Chinese wisdom or Chinese humility. Hide your strength and bide your time. And once I landed, this is the Chongqing I saw. Modern roads, lots of vehicles, modern buildings. And this is Chongqing in the evening, and this is Chongqing at night. Well lighted up. In fact, I think it's as good, maybe better than many of the modern cities I've seen. These are just crisscross expressways, one on top of the other. If you look at it, this is in Chongqing, and this is, I will tell you, is a GPS nightmare. At the bottom, you see there's something that looks like, in Singapore, we call it MBS, which Dr. Bay says I'm staying in one of this out there. Don't believe him. If you see a ship on top here, it is Singapore Marina Bay Sands. But in Chongqing, there are lots of boats down here and ships down here. And this is part of the Yangtze, the great Yangtze River. This picture on my right reminds me of my childhood days where I was growing up in the slums of Singapore, Chinatown. And when I look through the end of the streets, I see people's park exactly like this. So really something very similar to my childhood days. My next speaker is Professor Zhang Lian, and his topic is the experience of HIFU with uterine fibroids in Chongqing. And this is the birthplace of ultrasound-guided HIFU. Let me introduce him. He's educated in Chongqing Medical University from 1982 to 1987, and he actually became a gastroenterologist, passing out in 1992. Then he went on to join Chongqing Medical University as the assistant professor of medicine. And in 1998, he went to San Diego, California, to become a postgraduate research scientist in the Division of Gastroenterology. And following that, he joined the Polymorphism Research Lab in California, San Diego. And from 2013 to now, at the present moment, he's professor, State Key Laboratory of Ultrasound Engineering in Medicine, co-founded by Ministry of Science and Technology and Chongqing Medical University. And of course, his interest area is high intensity focused ultrasound for the solid fibroids. I present to you Professor Zhang Lian, Secretary General of ISMIVS, Professor Chongqing Medical University, and his topic, the experience of HIFU with uterine fibroids in Chongqing, the birthplace of ultrasound-guided HIFU. Professor Zhang Lian, my teacher.
Thank you, Dr. Li, and good evening. It's my great honor to be here and have the chance to share this experience with you guys. First, let me, right there. Yes. So about this technique, about high intensity focus ultrasound, and I think everybody already knew about it. Here, I still want to briefly introduce about this technique and how it works. This is a transducer. The ultrasound beams were generated from this transducer and focused at just some distance away from the surface of this transducer. During the treatment, the ultrasound beams could penetrate the human body and just focused at the target. When the temperature increased to 65 degrees, the growths occurred from the monitoring image, we can see the changes. From the ultrasound, we can see the grayscale changes like this. So from MRI, we can see more clearly like this, the temperature changes is a focal region. Please pay attention. No color changes around the focal region and also in the acoustic pathway. It means the energy just focus at the target. Let's say it again. You can see different color indicate different temperature. And the red color here, it means the temperature already over 65 degrees. So this technique was first proposed by Lin in 1940s. In 1950s, Dr. Fry confirmed this technique might be used in clinical practice. So this is the first prototype he made in Illinois. So this technique was not developed at that time because there was no adequate targeting method during that time until 1980s with the development of the diagnostic image. This HIFU received international attention again. So in 1988, Professor Wang in Chongqing Medical University, he started this project. This is transducer he made at that time. You can see the black box. We can see the ultrasound beams, and we can also see the focal region here. So we call this focal region as the acoustic focal region here. And after 10 years basic research, in 1997, Professor Wang proposed he proposed like the biological focal region, the concept of the BFR. So after 10 years basic research, in 1997, this technique was first used in clinic to treat the patient. This was the first patient in the whole wide world we treated using high intensity focused ultrasound. This patient was 17 years old at that time with osteosarcoma. You can see that before the SPECT CT shows a tumor here. Here is after. So the treatment was successful. Since that time, ultrasound-guided HIFU was used to treat different types of solid tumors, like liver cancer, pancreatic cancer, also kidney cancer, and bone tumors, and also others. Of course, uterine fibroids, and also adenomyosis. So in 2004, the US FDA approved using MR-guided focused ultrasound surgery to treat uterine fibroids. Now, there are two types HIFU system available in the market. One, like we said, is the ultrasound-guided HIFU. Another type, MRI-guided HIFU. So in our university, we have both. We have MRI-guided HIFU and also ultrasound-guided HIFU. Based on my experience, so here is a comparison of the two systems, two technologies. So MRI-guided HIFU, of course, we can use this to monitor the temperature. And we can see the temperature changes at the focal region. This is an advantage of MR-guided HIFU. But for those, because the bore size was too small and it limited the transducer size, also the movement range. So it's difficult to make the powerful transducer. That's why for ultrasound-guided HIFU, like we have the much range of the much wide of the movement range of the transducer. Of course, it's easy for us to position the patient during the treatment, and also the treatment time and also the room time is much less. And of course, the cost is much less. And for the indication, ultrasonic HIFU, like I already mentioned, is much more. And most important, like Dr. Lee already mentioned, the ultrasonic HIFU is easier for the gynecologist to use. So there's comparison of the two types of systems. So now I'm just focused on ultrasonic HIFU for uterine fibroids from Chongqing. That's Chongqing, the experience from Chongqing. So in Chongqing, in China, we started this project in 2000. The first case with uterine fibroid was treated by Professor Wang from Beijing. Between 2000 to 2005, in this stage is a clinic study. We didn't treat so many patients, but we optimized the indication, and also we optimized the protocol for HIFU treatment for uterine fibroids. From 2005, this technique, the ultrasonic guided HIFU, was used in clinic, for routine clinic practice. So 2007, we started to use HIFU to treat adrenal meiosis. Now, we also, in China, the gynecologists, they use ultrasonic guided HIFU to treat different diseases, even like blind diseases of the uterus, and also other indications. So now I'm just want to share you the experience at the beginning. Like after the clinic studies, 2006, we use this technique to treat patients in clinic routine practice. So between 2006 and 2009, in our center, we treated 757 patients. Like they have the solitary uterine fibroids and also multiple uterine fibroids. This is the baseline characteristics of this patient with uterine fibroids, and you can see the age. They are young. Actually, average age of this patient is 38 years old, and we treat a different type of the uterine fibroids. That's submucosal fibroids and intramural fibroids, and also subserous fibroids. The lung perfused volume ratio achieved in this stage was over 80%. So you can see the symptoms improvement because during this time, we tried our best to follow up every case, and always, like the MRI was free at this time, so that's why we get very good data. So you can see this before the symptom severity score is almost 60 points, and 3 months later, after HIFU treatment, the symptoms improved, and like you can see, these symptoms improved, sustained for 3 years old. At the end of the 3 years, we will follow up stop. So here you can see the volume of the fibroids is before. Here, 3 months, 6 months, and here 3 years after HIFU. So you can see the shrinkage rate from this line. At the end of the 3 years, the shrinkage rate is almost 90%. So this before, like this case, this patient had multiple uterine fibroids. You can see MRI shows like the contrasting the perfusion of this fibroid, and you can see the small one and also the bigger one. This patient had symptoms, so she didn't want to go to surgery. But when they have HIFU, we treated this patient with the ultrasonic guided HIFU. This is one day after HIFU treatment. you can see this, just this section, this slice, there are 5 fibroids. This one and this one here, and here, very small one here. All these were treated by HIFU. So all completely ablated. Here is 4 months after that. You can see the shape of the uterus was much better, more beautiful than before. And also the treated fibroids almost disappeared, all of them. Only we saw this one, a small part of the tumor, treated tumor still there, almost gone. So this shows how it changes because it's a non-invasive. We didn't move the fibroids out, but after treatment, the tumor get the shrink and also disappeared in some time after treatment. So you may ask if about the reintervention rate. Here is a study from the US, Stewart, and probably you guys already knew about her. And she performed a study like this figure. You can see this is about probability of the reintervention. And this is a lung perfused volume ratio. Here you can see if the lung perfused volume ratio over 70% and the 2 years recurrence rate just around 10%. Here is another study, actually, like they follow up the patients after myomectomy. Then you can see here, 2 years, here 2 years, here is a, like say, over 10%. After myomectomy, after the patient had 2 years, like they had a 10% reintervention rate. So it means if the lung perfused volume reach over 70%, the results, the reintervention rate is comparable with myomectomy. Here is another. We can see this table. This is from National Institute for Health and Clinical Excellence of UK. They presented this data 2011. You can see this result, of course, from after MRI-guided focused ultrasound surgery. This paper is from the US. You can see if the lung perfused volume ratio is around 16%, then 1 year intervention rate was 77%. And here is if the lung perfused volume ratio reach 55%, the 1 year, the 12-month reintervention rate was 10%. So it means with the lung perfused volume ratio higher, the reintervention rate was much lower. So now I share with you some cases like this case. This patient had a fibroid located the right uterine wall of the uterus, and the size was 5.5 in diameter. Here, 1 day after that, the MRI shows the fibroid was completely ablated. It means if we choose the right patient and we can achieve completely ablation of the fibroid, just like we perform myomectomy. So you may also ask about how many fibroids we can treat in one session. Here, I just want to show you, like this patient actually, if the gynecology wants to do this, probably just hysterectomy, but the patient refused. She came to our center. You can see how many. I counted more than 20. So, but the blood supply was not rich. So I think we can treat with a HIFU. So here you can see different slides. Then 1 day after HIFU treatment, with just one session, you can see so many. The bigger one and the smaller, we all ablated. So It means no matter how many, and just based on the blood supply, even like this, we treat like just 200 minutes, we finish the treatment. So we also can use this for other, for like the diffuse uterine myometosis. We treat some cases like this patient. She was 44 years old. She married, but no child, presented with dysmenorrhea and menorrhagia. Her mother and her sister had a hysterectomy because of the same reason, but she didn't want to have a hysterectomy. This her MRI. You can say how many uterine fibroids. We cannot count. We don't know how many. The numbers we cannot count. So, but from MRI, the T2 weighted image, it shows hypointensity. It means the blood supply was RH. It's sensitive to HIFU. So, like here, the contrast ultrasound before HIFU treatment. So it also indicates the blood supply was RH. We discussed with the patient, we may perform 2 sessions of HIFU treatment because so many. But the first session, I said, we just want to ablate those varicose symptoms, like the protruding to the uterine cavity, varicose, menorrhagia, and also dysmenorrhea. So that's our plan. She agreed. Then we treat this patient. You can see this MRI 1 day after HIFU treatment, that's T2. And here, this is contrast enhanced ultrasound. You can see low perfusion in this fibroids. So after the first session of HIFU treatment, the patient, the first period, the menstruation volume already decreased. And this is a transverse view of this patient. You can see those fibroids were ablated. So the symptoms improved, and anemia also subsided. The hemoglobin get normal. So now I'm going to share with you about the practical outcomes after HIFU treatment. There are many papers already presented and published. Here I just want to show you, like this is the first HIFU baby from our center. Oh, of course, in China is the first one. We got the permission to use these pictures. She was 29 years old. She married, but didn't get pregnant because of the fibroid. At that time, in our protocol, we didn't use this for those patients who want to conceive at that time. But this one, she said she didn't want to go to surgery. She came to us. Then we treat this patient. It was very lucky. So after HIFU treatment, 6 months later, she conceived, and no any complications during the pregnancy, also like the delivery. But of course, the first case we performed cesarean section. Now, I just want to show you why HIFU can use to treat the patients who want to get babies in the future. Like this is the case with multiple uterine fibroids. And you can see from this, there are so many in here, at least I think 9 in this slice. Here. I just counted the 9 fibroids, but the blood supply was RH. So we treat this one very easy. You can see this 1 day after HIFU treatment, this bigger one is this one. And this smaller here and here, yes, just like this. All of this we completed. Just pay attention to this image. Here is a endometrium, no damage. And you can see the fibroids, the tissue between the fibroids, the perfusion was normal, no damage. So for those like this, even multiple uterine fibroids, we can precisely ablate the fibroid without damage to the tissues between the fibroids. It means the conceived time should be much shorter than myomectomy. This patient actually we treated 2013, and you can see the conceived time just 1 month after HIFU. Actually, we told her just wait for 6 months at least, but she thought she didn't get pregnant before, so then she didn't do anything, then conceived. But it was very lucky. So during she delivered a baby at terms during the pregnancy, and also they didn't have any complication. Here is another case we treated in 2011. This patient had a submucosal fibroid. You can see from here, she had symptoms. The menstruation volume was large, and we ablated this fibroid. You can see contrast ultrasound. This T2, here contrast ultrasound image. The contrast enhanced MRI. The fibroid was completely ablated. This patient waited for 6 months and get pregnant. She delivered a baby by vaginal. Also, probably we also want to know if this patient, if they worry about it, like the uterine cavity adhesion, like this case, like type 2 submucosal fibroid, and you can see the endometrium here. So how about this case? Because they want to conceive soon, so we have to protect to avoid the damage to the endometrium. Like we performed the treatment, you can see the before and here after. The fibroid was completely ablated. And here you can see the transverse view. Here is a fibroid, no perfusion here, but here is the endometrium. The tissue between the fibroid, like here, like the tissue, the perfusion was normal. So no damage to the smooth, normal tissue. So for this kind of case, probably before have treatment, we can talk to the patient because we want to protect to avoid the damage to the endometrium. So the symptoms improvement may be, not immediately after treatment, because with the shrinkage of the fibroid, then the symptoms will be improved. So 3 months later, the symptoms improved. So we can tell this patient maybe 6 months later can try to conceive. So like for this kind of patient, it's difficult for us to treat with hysteroscopic and also laparoscopic surgery. But for HIFU, maybe offer this patient a better way to do that. So thank you very much. I hope you guys stay safe and see you soon in Chongqing. Thanks.
Thank you very much. That was Professor Zhang Lian. He's the teacher, chief trainer. Under his umbrella, there are about 50 to 60 trainers that he sends all over the world to guide us in the performance of HIFU. And I think what is spoken is HIFU is promising as an alternative and maybe gives an answer to all those difficulties we face if we do laparoscopic myomectomy. All of you, for question and answers, you can either raise your hand if I can see you, or you can write it down, or your questions. But I would like to take this opportunity just to have a special request. A special request to Professor Osamu Tsuzumi. Hi, Professor Osamu Tsuzumi, can you hear me? You have to, your microphone has to be on.
Yeah.
Okay, Professor Osamu Tsuzumi, I know I have a special request because I came across a Japanese paper. It was a classification of adenomyosis by a Japanese group of doctors. I thought you're the best person to explain because not many of us read Japanese. Can you please show us your presentation, the classification of MRI classification of adenomyosis? Over to you.
Okay. I'm a laparoscopist and also reproductive laparoscopist. So I'm very interested in adenomyosis. And this time, I'm going to explain Japanese paper. This one. And
I think it's this one.
Yeah.
Okay. And
Yes.
Can you?
Yes, I can see your painting. Yes.
You can see. So, yeah. Some Japanese describe the paper and origin of adenomyosis, maybe subtypes, 3 subtypes. And one is intrinsic invasion from endometrium.
Mm-hmm.
And second one, this is as shown in the slide. Intrinsic one and most popular cases are 59. And second one is extrinsic. There invasion from outside. Okay. And third one maybe you can see in the slide, figure 3. Yes. And de novo intramural one, maybe de novo adenomyosis. Number of cases 22. So there are several pathophysiology of adenomyosis, and we may treat depend on the pathophysiology of the adenomyosis. And I'm interested in application of HIFU because surgery is sometimes very difficult for adenomyosis. Okay.
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 Thank you very much. We will have more discussions on adenomyosis in episode 4. We'll come back to adenomyosis in episode 4. But right now, are there any questions from the audience? If not, then let me ask the questions that was asked in the last episode. Let me go to the laparoscopic surgeons, the presenters on the first talk and second talk. Professor Bernard Chen and my good friend, Dr. Bae Swan Tiong. There's always this perennial question. Is there a size of the fibroid that you would tell your younger doctors not to operate? In other words, is there a limit to the size of a fibroid that you would not operate? Maybe Is Bernard there?
Yes. Can you hear me?
I can hear you.
Okay, great. Okay, so well, I heard your questions. Well, essentially, there's no hard guidelines as to what is the upper limit of the size of a fibroid before we would embark on laparoscopy. Again, size, in many things, is relative. So we always tell our colleagues is that it's not an absolute number, but it's something that you want to look at the patient as a whole, such as the patient's build, of course, the size of the fibroid, previous pregnancy, etc. That will make a lot of difference when you come to performing laparoscopy. For example, I mean, if you have a patient who is 1.65 meter tall and then had delivered 2 babies before and now have a fibroid about 10 centimeter, it will be very different for the surgeon if the patient were to be 1.55, never delivered baby before, fibroids the same, 10 centimeter. So I think that's why this, we always say there's no real absolute numbers to follow. But in general, for Asian population, I would think that you want to perform surgery comfortably, laparoscopy without unduly prolonged surgery, prolonged surgical time. 10, 12 centimeters will be, I would think, will be something comfortable for most of our colleagues. And of course, the other factor to consider is also the number. We are not looking at the size alone, but how many fibroids the patient has. In fact, we were doing quite a few surgery the last 2 weeks. Previous week, we have a patient who had not so big fibroids, but there were many of them. I think we removed about 8 or 10 fibroids, but they were like in the range of about upper range of the size was probably about 7 to 8 centimeter. But it took a long time because it's a repetitive surgery. Take out one, take out another one, take out another one. So if you to compare somebody who has 6, 7 cm fibroids, but there were multiple of them, then compared to somebody who has one single fibroid, 10 centimeter, one single piece of it, then I would think that maybe the one single piece, 10 or 12 centimeter, could be easier to perform. So again, as I say, I think to summarize, there's really no hard and fast rule as to what is the correct size to do laparoscopy. Is relative. Other factors to consider, including the patient's physics, including the patient's parity, and of course, the number as well. I hope that sort of explained.
Thank you. Okay, quick question. I know you are the teaching professor and you have a lot of younger doctors under you. So do you morcellate within the bag in laparoscopic myomectomy?
Well, actually, ever since the pregnant women and children incident, we have been trying out the various containment technique. So ever since then, in fact, we have been largely performing our power morcellations in bag. Today, if you look at AAGR, I think we have been starting doing this both. Initially, we started performing morcellation in bag for older women, as what Dr. Bay has mentioned, because the risk of coming across a leiomyosarc, basically you are looking at the older patient. Just look at a brief sharing of the statistics that I've seen over the last 10 years. I'm looking at about 1 in 1,000. Laparoscopy, we will see about every 1,000 cases, you probably see about 1 leiomyosarc inadvertently morcellated. So the number is not that big. But of course, if you look at everything, look at all the various literature, you're looking at 0.1 to 0.5. I think all these are numbers reasonable depending on selection of cases and so on. So if you look at the number, yes, it's not high. If you look at 40 and above, basically most of the in fact, all the patients that we encountered leiomyosarc inadvertently morcellated were patients in the older age group, 40 and above. But of course, if you look at the literature, you know that leiomyosarc can even occur in women who are even younger than that, maybe in their 30s. And the other consideration, as what Bay has mentioned, is that because we do see disseminated leiomyomatosis. In fact, we have one patient now pending surgery. The patient has a previous laparoscopic myomectomy, and unfortunately, I think she has growing lumps and bumps everywhere in the peritoneal cavity. And this is not the first time we have seen cases like that. So that's why, to mitigate this so-called complications of morcellations, we feel that morcellating in the back makes sense. And I think it is technically not difficult. It's just that we retrieve ovarian specimens or other specimens in the back most of the time. Even if we just do a salpingectomy for ectopic pregnancy, it's good to use a bag to scoop it up so that to minimize spillage of whatever content, be it POC, be it ovarian cyst. So I really don't see a big concern as to why, just because it's a fibroid, we are treating it differently, because we do know the inherent risk, be it disseminated benign diseases or disseminating a cancer.
Okay, thank you. Okay, let's hear from Professor Osamu Tsuzumi, the land of the rising sun. Okay, you have to unmute, Professor Tsuzumi.
Yes. We usually use in-back morcellation. Yeah. Mostly, our patients are conscious about the FDA program. So they ask, is it safe? So we assure you, them, in-back morcellation is safer. So mostly we use in-back morcellation, but not all in Japan, of course.
Okay, what about you? Do you have a guideline how big a fibroid you to me? Do you have such a guide? In other words, if it's more than do laparoscopic myomectomy or you do open myomectomy?
In case of huge one and maybe 5 or 10 fibro, we use laparoscopically assisted myomectomy. Maybe 3 centimeter incision. We apply LAM, laparoscopic assisted myomectomy, and maybe 6 centimeter single one with laparoscopic myomectomy, and larger one and multiple one we use laparoscopy and assisted one. Yeah.
So in all your experience, for so many years, how many leiomyosarcomas have you come across?
We can exclude sarcoma by MRI and blood testing. And I have never experienced malignancy during this 20 or 25 years experience.
Okay, so it's again very rare. Let me come to the most difficult part for my good friend Dr. Bei Suan Tiao, who is sitting so comfortably there. Okay, Dr. Bei, do you have, since you are in private practice, and well, we always say in private practice we are literally alone, do you have a guideline on, say, the number of fibroids you do laparoscopically or the size of the fibroid you do laparoscopically? And do you morcellate? Do you still morcellate in the back nowadays?
Thanks for the questions, Kim Wai. Essentially, how hard I try to do the laparoscopic myomectomy, I think to me, one of the important criteria is the future fertility requirement of the patient. For those that no longer desire future childbearing, I'm quite gung-ho in a way that if you really want to, I'll basically try my best to achieve that, because most of the time we should be able to control the hemorrhage and able to achieve complete the surgery without much problem. However, I have reservations coming to patients who still wish to become pregnant or have infertility as a problem. I will be much more careful in a situation like this. And in fact, if they have a deep-seated big intramural fibroid, I would be rather reluctant to actually offer them laparoscopic myomectomy. No doubt, laparoscopic suturing can be done pretty well, but I feel somehow at the bottom of my heart that I perhaps can do an even better job openly. So that's one thing. And the next question is about how often do I use the morcellation back? Well, you know, I'm a visiting faculty to MIS unit in KK, so I'm somehow influenced by them as well, especially when they warn me about all the scary tales. Right now, what I do personally is that for the younger patient, those that is below 40 or 45, I do still do naked power morcellation, in other words, without back. And I enjoy doing it without condom. Right, but for the bigger one and older patients, yes, I would tend to use morcellation back nowadays.
So in your so many years, 20 over years of experience in this, how many fibroids have you come across that's leiomyosarcoma? I just want to have a consensus.
None. I have not come across one. Fortunately, touch wood. Yep.
None is an honest answer to many of us.
Yep.
Okay. All right. That's a question from Dr. Bachu Singh. Dr. Singh, could you please introduce yourself and ask the question? Dr. Bachu Singh. So how do I? So I do it or they do it?
They do it.
Okay. Can the controllers please tune in to Dr. Bachu Singh? Yes. Dr. Bachu Singh, yes. Yes. Unmute. Okay. Okay. While you're figuring out who is who, can we go on to Dr. Ishaq Abdul? I think he's on the line now.
Yes. Good day to everyone. I just want to thank you for giving us this highly elucidating presentations. Thank you very much. My question goes. Sorry, my name is Ishaq Abdul, a professor. A professor of Obs and Gynae from the University of Ilorin, Nigeria.
Okay, good.
Good. And I'm quite interested in this new technology because of so many advantages that have been listed. I just want to bring out my concerns as regards the sizes of the fibroids after HIFU. It does look to me that it takes a little while before normal sizes are returned to by the, in the treated fibroids. In the treated uterine uterus or uteruses. Is this usual observation, or it takes a little while before the uterus return to normal or close to normal sizes?
Sorry,
You don't understand my question. My question is, after HIFU, after HIFU treatment, I tend to see that the MRI scans still show a bit of enlargement of the uterine size.
Okay. Okay.
So how long does it take for the uterine size to return back to normal sizes, even after the shrinkage of the fibroid volumes in them? It didn't look like it goes back to normal quickly.
Sure. I leave it to Professor Zhang Lian to answer that. Professor Zhang Lian, can you please answer the question?
Yes, actually, like the average shrink, the average shrink rate is like 3 months. The shrinkage is like 30%. 6 months after HIFU, shrinkage rate was around 50%. Like I already showed, like in my PowerPoint, in my one slide, like at the end of the 3 years, 90% of the shrinkage of that. So it depends. Like the case I showed you, like just 4 months after that, the size of the uterine almost getting normal. So it depends on the size of the fibroids and the number of the fibroids. So
thank you very much.
I can just tell you the average shrinkage rate of the uterine fibroids. But it can be getting normal, you know, in some time after HIFU.
That's quite reassuring. Thank you very much for your presentation.
Thank you.
I appreciate you. Thank you.
I think his main point is he noticed that the fibroids has shrunken in size. I think that's what he's trying to ask. But let me follow on that. You see, I think I give an example of adenomyosis. Adenomyosis hasn't really got a border. So, and to do a MRI post-operatively to check on the adenomyosis is very expensive in Singapore. So what I do is, instead of measuring, trying to figure out where the borders of the adenomyosis by using MRI, I measure the whole uterine length, size, and depth. And you find that, yes, in adenomyosis, once you're treated, they do shrink in size. And if you have done ultrasound follow-up of the fibroids that has shrunken, most of them, I would say, would have reduced in size. Okay, I think we have a question from we got Dr. Batu Singh on the line. Dr. Batu Singh, could you introduce yourself? Dr. Batu Singh, can you hear me? I think your sound is off. You have to unmute your sound. Please unmute. Yes. Looks like unmuting is a problem. Huh? Sorry, Dr. Batu Singh, can you please unmute your microphone? Any more questions? Yeah. Okay, while you're trying to look for the button to unmute, maybe we take this opportunity to ask Professor Zhang Lian, which is the question that everybody asks. Can MRI help in the diagnosis of leiomyosarcomas? I think you have the most experience on it. Can you show your slides now?
Sure, thanks. Just a moment. So this, yeah. So I just made this slide today. Actually, this just Dr. Wang Qian and Professor Li and Dr. Li, you know her. So she did this review, actually retrospective review from 9 centers, 9 hospitals between 2008 to 2019. So the total patients was more than 15,000. actually initial diagnosis of uterine fibroids, they came for HIFU treatment. Then came to, after review the MRI, 46 patients were suspected to be sarcoma. And those 46 patients were sent to for open surgery. And 12 of them were confirmed by surgery was sarcoma, but that is not leiomyosarcoma, but endometrial stromal sarcoma, most of them. So it's different from the publications. And also the other 50,713 patients underwent HIFU treatment. And because at the beginning, for the MRI, actually, we were not so sure if it can make the diagnosis accurately. So we have another, to follow up, just to make sure if some patient missed this diagnosed. So among these patients, eight of them were suspected to be sarcoma at the 3 and 6 months follow-up after HIFU, and 6 of them were confirmed by surgery. But it's because HIFU was used to treat even malignant tumors. So for those cases, we didn't have the catastrophic consequences after death, because after surgery, no other bad consequences. So here, for the answer, I think MRI really helps. Like the pre-HIFU, even pre-laproscopic, I think MRI really helps. So like for those 15,000 cases, totally 18 cases were sarcoma. Like the ratio from this group of patients for this population is like 101%. So it's very low, but the difference just like these most of them like the endometrial stromal sarcoma. So just because of the age of this patient, they are younger, because when this thing comes to for HIFU treatment, they are younger than those. The average of this patient is around 41 years old. So probably just because of this reason. Actually, for the MRI, you can say from here, and we often use T2 weighted image. This T2 means like you can see the water, like the bladder white. So that's T2. So T2 weighted image for uterine fibroids may be hypo intense, like the black. And here, hyper intense fibroids, it means white. So from there, you can see the margin was clear, either this one and this one. And for the contrast ultrasound, usually we don't see the margin is clear. And you see the perfusion was even for this one. But for this, you can see even like this shape was round, the shape, and also margin, and also the intensity on T2 weighted image. And from this one, you can see completely different. Like this one, the shape was not round, is irregular. And also you can see the hyper intensity on T2. And you see lobulated, the fibroid here. So you can see even from the contrast is different. So from this image, we can tell the difference between these two. So like this case, leiomyosarcoma, like this case, even like this part, this fibroid, and here, hyperintensity and like some necrosis in the tumor, and the contrast, low perfusion in this area. So this part was confirmed sarcoma. The outside this area, uterine fibroids. So that's why I think this evidence some uterine fibroids can become like leiomyosarcoma in the future. So I just want to share with you some like cases. We already knew about the different MRI features. Like this case, how about the diagnosis? Probably we don't know, but we can say this is not uterine fibroids because you can say MRI hyper intensity on T2 because white, and the margin, we cannot see the margin here. So, and also the contrast ultrasound, a contrast MRI, contrast enhanced MRI shows there was low perfusion, poor perfusion in the center. So the margin was not clear. For this one, if you cannot, you don't know if it's a sarcoma or something else, but you can make sure that's not uterine fibroids. Actually, these features are sarcoma. So like this case, when you have more experience, you know exactly what it is. Even like at the beginning, my group, my doctors, when they're younger, probably at the beginning, they don't have that much experience, but now they are experienced with reading MRI. So for this one, hyperintensity on T2, margin is not clear, necrosis is observed in the tumor on contrast MRI. Of this, it helps us to make the diagnosis. And this one actually I just got last week. And my doctor from another sent me this image because after she reviewed this patient, this MRI of this patient, she said, hey, I suspect this one is sarcoma. She sent this to me, I said yes, because on T2 weighted image, hyper intensity. Compare this one with this one. This uterine fibroid, or this one hyper intensity. But you can see here, multiple nodules or nodulated inside. And for the contrast enhanced MRI, we see necrosis here. Also, the margin was not clear. So we made the diagnosis. We said this is a sarcoma, just sent to for the open surgery. And after the surgery, actually during the treatment, during the surgery, the frozen section examination showed malignant, but didn't make the diagnosis. And here, after that, the final pathological diagnosis was leiomyosarcoma, this one. This one, benign. So even from this one, we can see the difference. So I think it helps a lot. Thank you. That's what I want to share with you guys.
Okay, I just saw a little image of the slide which shows the complications. You must have finished and tell us what are the common complications in HIFU treatment of fibroids or adenomyosis. I know
okay, thanks, Dr. Lee. Actually, this one I just leave this here. This is from my paper we just published in 2018. Actually, more than 20,000 patients from different centers, like the real world data. So from here, you can see the most common complications, just like class A, just like some pain, something like that. You don't need any treatment. And also class B, maybe lower abdominal pain. And because this pain is different from this one, maybe severe, longer, but low, don't need any treatment for this one. So I think we should pay attention, like say class C and D, class A above. For this one, like skin burns, that's the most common complications during HIFU treatment for uterine fibroids and adrenal meiosis. But you can see right now, the incidence, just like 0.14%, which is very low. And also some patients have the leg pain. Also, like the class C and class D, the big number, just like below 0.5%. It means right now this technique is very safe. So here I just want to show you the serious complication of class C and above in each year. 2011 you can say almost 1%, but 2012 is around 0.6%, and after 2014 is below that. And you can see right now with the improvement of the technique and also the experience of the doctors have, these complications decreased. So right now I think it's pretty safe for this technique. Thanks.
Okay, thank you. Can you go back to your first slide on the class A, B, and C again?
Yeah.
Okay, sure. This just for the benefit of those younger doctors, what Professor Chang has done is class A very mild. In other words, mild low abdominal pain, which you get it anyway in a laparoscopy or laparotomy. Sacrococcygeal pain is 10%. If you lie something on the flat surface for too long, we get it. Abnormal vaginal discharge is very common after surgeries. Lower limb paresthesis, nausea, vomiting, you get it also after anesthesia. Erythema on the skin, redness on the skin, we get it also when you put the plaster on the skin. Fever, which is actually a post-operative reaction, very common. Hematuria, we get it when you put the Foley. So I'm very happy that under class D, which is a concern to many of the laparoscopic surgeons, is your bowel injury is very low. And this 0.01% is much lower than we would have done through open surgery or laparoscopic surgery. And I don't see any of these scary blood vessel injuries like we normally encounter rarely in laparoscopic or laparotomy. Thank you very much, Professor Chang.
Thank you.
Okay. So have we got back? Can we go back to Dr. Singh? Have we got him again?
Yes.
Well, I saw a hands up for a long time, Dr. Bachit Singh. If not, then are there any more questions from anybody else? I see. Nobody else. Okay, sure. If not, before I end the session, before I say goodbye, coming up next on a Thursday will be another group of experts.
Yes,
we have Professor Ben, somebody I'm going to meet for the first time, Dr. Gopinath from India, and then a great friend of mine, a very good speaker. In fact, I always say he speaks like a minister. Is Dr. Salvarat from Malaysia, and somebody very well known from Hong Kong and China and Australia is my good friend Professor Felix Wong, and last but not least, all the way from South Africa is Dr. Raymond Zetson, and they will be speaking to us next 2 Thursdays from now. It's on the 9th of July, it's a Thursday, and the topics are all on the board. And I would like to say thank you to all the speakers, chairpersons, panelists, audience. I'm Dr. Lee from Singapore ONG. Thank you, and from here is good evening and good night. Thank you very much, everybody.
Thank you.
Okay, thanks. Thank you. Bye.
Thank you.
Thank you. Thank you very much, sir. Thank you.
Thank you.
Good night.
Bye-bye.
Good night. Thanks. Thank you.
Thank you.
Thank you.